नहीं, मुझे लगा चार्जिंग itu waktu sekolah ya, itu ini sekolah apa? आपने नहीं पता है बहुत से होते हैं पहले तो बहुत अच्छा करें भाई देखो तब तो लगे लैपटॉप सेल मेरे पास करो
Thank you, sir. Good morning, everyone. Today I am here to speak on a topic which is a very critical topic for hepatology, pediatric hepatology, transplant, and the hematology team. So it is prediction of response to plasma exchange in acute liver failure, a topic on which there is absolutely zero literature as of today. Now, there are several studies, RCTs, meta-analysis, propensity match studies in children, and the guidelines now recommend plasma exchange for acute liver failure. But none of these studies address how exactly do we monitor once we start the patients on plasma exchange. So what we all know that TP plays haywire with the biochemical parameters. The exact biochemical parameters like INR, bilirubin, ammonia, everything comes down as soon as you do plasma exchange. Now, is that the effect of the endogenous clearance by the plasma exchange, replacement of the donor recipient plasma with the donor plasma, or actual improvement in the biochemical trajectory of the hepatic recovery? That we cannot say. And these parameters are very critical because they are part of any and every prognostic score. INR is part of all prognostic scores, whether it is KCH, PEDS HIV, which we use in hepatitis A, or any other model. So the trend of conventional lab parameters that we follow, that there should be improvement in INR, there should be improvement in bilirubin, all that stuff, ammonia, that is not accurately reflected in these patients who are undergoing plasma exchange, as this can be just done by due to the effect of replacing the plasma. And this is further compounded due to repeated sessions. Woods and Jacobs way back in 1986 had shown that any substance which is present in the plasma, when you do a plasma exchange, whether it is plasma proteins, whether it is toxins, whether it is cytokines, will be reduced by 60 to 80% depending on the volume of plasma that you exchange. Then there will be a gradual rebound due to reaccumulation. Then if you do the second exchange, it will further go down and then it will rebound. So there is a cycling process where there will be fall and rebound. And we usually tend to do up to 3 plasma exchange. So this is very difficult to predict. One way which I think, which is not described as such, but one way which I think is what we can do is we can maybe check these peaks. If these peaks are going down, that may be an indirect indicator that the patient is improving. And if these troughs are also going down, that is also an indicator that the patient may be improving. What would happen in non-responder? If you do a plasma exchange, everything will go down, but it will accumulate very rapidly. Again, it will go down with the second plasma exchange. Again, it will accumulate. So anything which is rebounding back, the peaks are not going down, may be a indicator of non-response to plasma exchange and need for liver transplantation. So let's go with a case. A day-to-day run-of-the-mill case that we get in ILBS. A 13-year-old female, hepatitis A-related ALF, jaundice to HE interval of only 3 days, HE grade 3, so intubated. INR was 4.24, ammonia was 396, bilirubin was 16.5. This is a classical patient who will never meet a KCH criteria, but is actually very sick. So we use PEDS HAV criteria 2/3 listed for transplant, and donor evaluation started. First plasma exchange done. INR immediately post plasma exchange was 1.9, which rebounded to 3.1. Ammonia was 301 and 168. A donor has become ready at this time point. What would the audience think? What would you do? Would you proceed with LT at this time point? Would you want to differ by doing another plasma exchange? Or would you not do anything? Actually, not do a plasma exchange and wait and watch the INR trend. What would you do? Those who say that proceed for LT right away. Okay, a few of them. Those who say that do another plasma exchange and watch, there is some response. Okay, there are a few. And those who say that no, don't do any further plasma exchange, just wait and watch the INR. Okay, so we have people raising hands in all, and that is what is actually happening. There is so much of conflicting opinion, there is so much of subjectivity that ultimately a decision cannot be made. And many people did not raise their hand, which I would assume they are too confused to actually raise hand in anything. So let's go forward and see what happened later. We did a second plasma exchange. That was what was decided after a lot of deliberation. Again, the INR went down, rebounded again to 2.8. Now, this was the time point we started feeling maybe the patient is not responding ammonia. Anyways, we went ahead and did the third plasma exchange, following which you can see that the INR rebounded only up to 1.7, and thereafter it gradually reduced to 1.5 and thereafter. So by day 5, everyone is clear. Now, this time point, I think all of us can say that this patient needs nothing. But problem is taking decision here. On day 2, day 3, day 4, that is when the decision making is critical, and there is absolutely nothing in literature to guide you how to take these decisions. So if I was asked the question how to dynamically predict the response to plasma exchange early on day 2 or day 3, I would put it is like this, that the markers of inflammation should be going down. So the markers of inflammation should be going down. That is, the pro-inflammatory cytokine should be going down, anti-inflammatory cytokine should be going up, microRNA signatures, organ failures and acidosis may also give a guide that markers of inflammation are going down or not. Then some studies have shown that regenerative markers, some studies have shown that rising AFP may be a good marker. But in our practice, we have not found this to be useful. Some have shown decreasing serum phosphate, which is actually a good guide, but we don't know the cutoffs, we don't know the levels, how do they change. Some have studied more than 25% fall in wall midline fracture as a predictor of response, improved hemodynamics, and monocyte phagocytic function. Now, these are actually difficult to do in a daily clinical practice. Day 2, you don't get the turnaround time with inflammatory cytokines is quite long, and even with the growth factors, it's quite long that you can actually take a clinical decision while the patient is with you. So ultimately, we get guided by trends in biochemistry, HE trend, organ failures, and prognostic scores, and which becomes very subjective. As we just saw, the opinion of the house was completely divided, almost 1/3, 1/3, 1/3, and many were unsure of where to raise their hands. So there are a few studies, like Dr. Anupam has done this study with us in pediatric acute liver failure, where he has shown that he can predict based on the spare reserve capacity where not to do plasma exchange. But then that is a question for another day. Today, we are talking about response. So then Dr. Rakhi's study has shown that pro-inflammatory markers will decrease, anti-inflammatory markers will rise, growth factors although decrease but doesn't affect the outcome. But again, the responders versus non-responders were not compared, and this was day 0 to day 5 comparison, and we need day 1, day 2, and how does it affect. So how do we predict response to TP? The question is again back to square one. Once the TP sessions have started, in an objective manner, in a reasonably quick time when the patient is with you and the donor is ready, LT is ready, preferably bedside. And to answer all these three, can ML models provide early objective prediction? So to answer this question, we did this study. Now, this is our ML workflow. And to be fair, this was done by my colleague from IIT, so I may not be able to answer intricate questions about this. But I have a fair idea and I may be able to answer that. And this is something like, this is my colleague whom I met while playing badminton in Siri Fort. So our famous tagline goes for CCD, like a lot can happen over a cup of coffee. So I think a lot of collaborations can happen over a game of badminton as well, if you are aware and open with your eyes and mind. So we use the Python kit here with Grid Search CV. Data pre-processing was done as is the routine ML workflow with 30 random permutations after dividing the cohort into training and validation set, and multiple 30 iterations were done because the sample size was low. Augmentation was applied only to the training data set. Hyperparameter tuning is kind of you tune your model to optimize your like optimizing your settings, like you optimize your settings of guitar before playing it. So it is something like that. You tune the model so that it has the best predictive efficacy once it starts learning from the training data set. Now, feature selection is the most critical step, though it was done in two steps. One was the preliminary selection done via clinical expertise was done by us, and then the final selection was done using RFECV, which is a technique, recursive feature elimination by cross-validation, done using LR as the base estimator and using other models as well. So the final models deployed were all these 5: random forest, logistic regression, gradient boost trees, XGBoost, which is a kind of tree model but advanced, and support vector machine. And after evaluating the models, the best 3 models, that is the logistic regression, XGBoost, and SVM, were incorporated into a web-based tool. So out of the patients till now, we have had 510 patients, but we have started doing plasma exchange only after 2017. So only 134 patients, and we do in very selected patients with great, with advanced, where we feel the outcomes are not going to be good. So we did plasma exchange in 134 patients. Those undergoing LT have been excluded because the outcome cannot be this way or that way. So ideally, I considered them among the non-responders, but this was what was decided when we planned the study. So the responders here are those who survived with their native liver, and non-responders are those who died. So we have only 2 parts, 51 and 59 out of 110 patients. And these patients were mainly hepatitis A, more than half of them, and 1/4 of them were indeterminate ALF. I'll spend a minute here to describe the time points, because that if you there has to be some clarity on these time points that we have used. So when we do 3 plasma exchange, suppose TP 1, 2, and 3, we label what we used was, we saw that we were anyway doing repeated tests, INR, ammonia, bilirubin. So we thought we'll use those tests because we have those tests in our HIS, but it was not done in a protocolized way when it was started in 2017 up to almost 2024. There was no set protocol. When do you do the test? So what we decided was, anything from ending of first plasma exchange to first 6 hours will be counted as T1. Similarly, T3 for that after second plasma exchange, and T5 for first 6 hours after third plasma exchange. What I'd like to point out more emphasize would be that T2 time point. This is a critical time point, that is around 12 to 18 hours away from the first plasma exchange. That is just before the second plasma exchange. T4 is 12 to 18 hours after second plasma exchange, just before the third plasma exchange. And T6 is 12 to 18 hours after third plasma exchange. So these biochemical parameters at T2, T4, T6 are done at least 12 hours away from the last plasma exchange which was done. So this is the baseline cohort of 110 patients. Most had grade 3-4 HE right at admission. Others progressed, or some did not progress to grade 3 to 4 HE, although they may have had high INR. And final 66%. Since 2021, we have started using CRRT in all patients with hyperammonemia and advanced hepatic encephalopathy. So 66% also received concomitant CRRT. Survival with native liver, I have shown 46%, and death was 53.6% in the cohort. Now coming to the feature selection, this is the important guide, like what features were actually used to determine the response, or to finally used in the model. So you can see that at point T0, 8 variables, at point T2, 6 variables, and at point T4, 9 variables were used. The variables marked in blue are dynamic variables which change over time, like INR, ammonia, it keeps changing. INR T2, ammonia T2, INR T2, T4, and so on. And variables marked in black are constant variables, which also affect the outcome. Now, HE grade has been marked as a constant variable because most of our patients were HE grade 3. Until we find the improvement in the INR, we don't start weaning or wake up the patient. So we cannot assess the dynamic change in HE. So HE has been marked as a static grade right at the time of admission. This is a feature importance ranking, which we can skip. Hyperparameter tuning, we can skip. This is basically to improve the model, tune the model just prior to we start training the model, we do this. So let's first verify whether what we had seen, that Woods and Jacobs, that thing, whether it actually happens. So if you see the trend in INR, you can clearly see that the INR, the blue is the non-responders, the orange is the responders. You can see that the responders, INR starts at lower, goes lower, but doesn't rebound after T2. This is something important. Second important thing to see is if you do a test at T1, you cannot differentiate between responders and non-responders. They will have similar, because you have done plasma exchange, INR will be same, ammonia will be same, bilirubin will be same. You cannot get any idea with those tests. Where is it important? At T2, where the non-responders start showing rebound, whereas responders shows a bit of rebound, but not as much as the non-responders. Similar things happen at T4 and T6, and T1, T3, T5 are not good times to do the test. So what this slide tells us is we should standardize the testing protocol of patients on plasma exchange in such a way that we do these biochemical parameters at least 12 to 18 hours post the last plasma exchange, where it can help us differentiate between and decide whether the patient is responding to our plasma exchange or not. Coming to the ammonia part, I skipped the bilirubin part because bilirubin, yes, there was a difference between responders and non-responders, but there was a lot of overlap, which we know because our patients were mainly hepatitis A. So even a lot of patients who are improving with hepatitis A will actually have rising bilirubin because they go into a kind of cholestatic phase. So bilirubin may keep on rising even when they are getting out of their ALF, which is a very normal and routinely observed phenomenon. Described phenomenon. Now coming to ammonia, you can see that there's a good differentiation between the non-responders who are higher and the responders who are at a lower level. Now, but issue here was 66% of patients were also receiving CRRT, and we know that CRRT clears smaller substances like ammonia much better than plasma exchange. So if we include ammonia, trend of ammonia in our model, was it the effect of CRRT which we are studying and not the response to TP? That was a question for which we had, but somehow that question would get answered because our model included use of CRRT, except at one time point at which at T4 we made a forced inclusion of CRRT into the model to account for the changes in ammonia. So these are the training set. Once we developed the model, once we decided these parameters, we selected the features, we put it for training on the training set, and we found that almost all the 5 models that we are evaluating did reasonably well with scores more than 80%, with more than 80% accuracy. And thereafter, we tested them separately on the validation part. And for the validation part, we found that 3 models, that is logistic regression, XGBoost, and support vector machine, were consistently showing good AUC for differentiation of non-responders to responders. What is important to note here is the specificity of the model is modest. This is partly intentional because we don't want a lot of, or we don't want a significant number of false positives, because we don't want any patient to miss out on the opportunity for liver transplant if the patient has slightest chance of not responding to plasma exchange. So the model is tuned in such a way that it is slightly bent towards, whenever there is a doubt, it would bend towards the decision of liver transplant, that is decision of non-response. So that has been tuned that way. That's why the specificity is low, but sensitivity and positive predictive value is fine. And AUC at T4 is lower. As you can see, it's only 70 to 75%. This is partly because some patients did not receive a complete set of plasma exchange, and that's why the numbers at T4 were less. And the testing protocol also had some missing data, which led to these smaller numbers, which could be the reason for lower AUC at T4. This is just the diagrammatic representation which showed the same thing, that LR, XGBoost, and SBM were the best performing models. So now we deployed this model onto the web-based tool, which has been hosted as of now on OnRender. But this is the most important part, because whatever you do, you can be a keyboard warrior and do all kind of predictive analysis for your entertainment. This will all remain an entertainment until you actually put it into clinical practice, or actually evaluate it in clinical practice. So this was done to address the gap between the predictive analysis and the bedside utility. So we use the input parameters. I'll be just showing you right now that we use the very readily available parameters like INR, ammonia. All of us have those parameters: etiology, HE grade, JE interval, age, ALT, and use of CRRT. And we use the three best models. So let me just quickly show you the model, how it works. So like suppose we have a patient, these are the real patients which I had just noted the UHID and the data. So I have entered one of these patient data. That patient has received, it asks for how many plasma exchange. So patient has received 2 plasma exchange. So it opens up the other values. So age, grade of hepatic encephalopathy, etiology, whether concomitant CRRT is being ongoing or not, jaundice to HE interval, ALT, and then if you enter 2, it opens 2 like baseline parameters after 12 to 18 hours after first plasma exchange, that is T2 parameters, and 12 to 18 hours after second plasma exchange. If you enter 3, there'll be another line. If you enter 1, there'll be one line less. And then you click on analyze, and it gives the prediction of mortality. What does prediction of non-response actually? Prediction of mortality actually. So using the three models, which are the best models, performing models. So this in this patient, it says that although we may feel that yes, this patient started with an INR of 4.7, it decreased to 2, and it was only 2.3 after second plasma exchange. We may feel that this patient is maybe going to improve, but actually what the parameter, the model tells us is that the risk of mortality is 73%, 77%, and 89% by the three models respectively. This patient ultimately succumbed to his illness. Let me show you another example, as I have, I think, 5 minutes more. So this patient underwent 1 plasma exchange, 15-year-old, grade 3 HE, almost same. Etiology was hepatitis A. Etiology is important because we have clearly shown that hepatitis A, even our paper, even Dr. Rakhi's paper has shown that hepatitis A may plasma exchange works much better. Wilson disease, it works much better. So etiology was important. Jaundice to HE interval. ALT was 3100. Sorry, 3100. INR was 4.3, almost same. 4.7 the previous patient was. 4.3. Ammonia almost again very similar. Started with the ammonia of 433. Previous patient started with 493. The INR after 18 hours of first plasma exchange was 1.8, and the ammonia was 271. Again, almost very similar, but INR was better. INR was significantly better. Ammonia was slightly better. Now you see the analysis in this patient, and it shows that so there is some, I think, issues with this right now. Maybe I have entered something wrongly, but it showed that this patient was showing low risk of mortality. Similarly, if I enter the data for that patient, maybe I have to just click it again. Yeah. So if I enter the data for the patient I described in the initial period, after the first plasma exchange, we are getting mortality of around 25, 30 or 30% using the tool. I'll just put the patient which I described initially. So first plasma exchange, this was when I asked you guys to give your opinion. 13-year-old with grade 3 HE, that was the finding in that patient. Hepatitis A, CRRT, yes. Jaundice to HE interval was 3 days. Baseline ALT was 1800. Then INR was 4.24, if you remember the case I showed. And ammonia was 396. INR had rebounded up to 3.1, and ammonia had rebounded to 168. So this was the data when I asked you, and there was divided opinions. Even in our team, there was a lot of divided opinions. But if you see that this was saying that the risk of mortality was between 25 to 35%. So this is how it can supplement your decision making. Obviously, it cannot replace the clinician in decision making, but it can supplement your decision making as of now. So what is the strength of this tool? Now, first thing is, it is an objective parameter. What we decide, my feeling may be different, your feeling may be completely different, and none of us may be wrong. But this is an objective parameter. This is the first tool, whether in adults or in pediatric, to assess the treatment response when the patient is on plasma exchange. We deliberately evaluated multiple ML classifiers because each ML classifier has its own strength and limitations. So we can reduce we can cover one's limitation with the other model's strength. It uses very simple, readily available parameters like INR you're anyways doing, bilirubin you're anyways doing, ammonia you're anyways doing. So easily available parameters. There was high concordance among ML classifiers, which increases our confidence. And when there is no concordance between ML classifiers, these situations also happen, are very difficult to actually decide. We use stringent feature selection, balanced CV, controlled model complexity, and we use judicious data augmentation. Obviously, if you try doing something like this, it will be full of limitations. As of now, there are a lot of limitations. That's why we are still just working on it and improving it every week. We are changing and adding more data so that the learning of the model is better. So the first important limitation is it is a single center data, where in our center, it's almost HAV, which is almost 60%. So it limits generalization to other populations. We are yet to do prospective or external validation. In principle, 3 centers have agreed to do, because it's just an observational study. So 3 centers have in principle agreed to do external validation for us. Relatively small sample size of 134 patients underwent plasma exchange and 110 were included, which is a small number for a ML model. I completely agree. But this number reflects the rarity of pediatric ALF. No other center has done maybe even 50 plasma exchange in pediatric acute liver failure. So this is the best that you can have. And on the other hand, you have nothing. You are comparing with no way to predict the outcome. So we anticipate that as the sample set increases, the model performance will improve. Concomitant CRRT, we believe, can be a confounder. We have included CRRT into the model, which strengthens our real world applicability, because nowadays everyone who is using plasma exchange is using CRRT. So it strengthens the actual real world applicability by using the CRRT as a feature in the model. But the ammonia kinetics is very complicated and can be affected by CRRT in unknown ways, which we cannot control for. We should have ideally done stratified ML models based on etiology stratification and CRRT use stratification, but that will again further limit our sample size and increase the risk of overfitting and model instability. Patients with ALF die of liver failure, but patients of ALF also die of sepsis. We have not been able to incorporate sepsis. We tried with ProCal, we tried with cultures, but we have not been able to incorporate sepsis into the model till date. Another very important reason, the tool gives a risk of mortality. Now, so it says 35% risk of mortality. Do you consider if the patient is going to survive not for LT, or what do you consider? Someone may say that 25% is too high a risk of mortality and I should proceed with LT. So it just gives a risk of mortality, but it doesn't define what cutoff will be a response. This again becomes subjective at that time point. And there is a risk of overfitting with XGBoost, which will always be there. So with these limitations, the future strategies would be to further train the model with increasing sample size, do the external plus prospective validation, and integrate the ML output when it is ready into real-time electronic hospital record systems. So to summarize, currently the prognostic modeling in ALF patients receiving TP is very arbitrary and completely subjective. Our model introduces objectivity, helps in early prediction of response to plasma exchange, and timely decisions for liver transplant based on SVM, XGBoost, and LR, which are the best models. We should standardize the biochemistry testing protocol, which should ideally be done 12 to 18 hours after each plasma exchange sessions. However, this model should only be considered as a preliminary framework, which requires refinement through larger data sets and external validation. Until then, can be only used in clinical studies. Thank you.
Thank you, Vikrant. That was a good attempt. Of course, you'll have some other comments. Mine first is that you should include bile acid.
Yes.
Because all others to me are markers of injury. You need to see what is the marker. Of course, you can include phosphorus, ONST, and others, but definitely bile acids, pre and post. And I think the analysis has already been done. To me, it's the most important. The clarity between markers of injury and markers of regeneration should be separated. To look into it. What you are looking into is maybe clearly. So the third is HE. Is a very important marker. I don't know if in your model you are adding
Yes, so we have HE, but we have it as a static model, not a dynamic model, because
Yeah.
once the patient is grade 3 and gets intubated, we cannot assess like day one. We don't know what's we assume that once the patient is intubated, he's in grade 3 HE till he gets weaning starts and we start weaning off the patient. He's on propofol, and so
Because ammonia to me has relatively limited, advantage. But if the patient has grade 4 versus grade 3 at entry, that should be separately assessed.
yes.
Of course, there are many other points. Comments from our Isha and maybe Rakhi. Rakhi.
Dr. Vikrant, very nice presentation. I would say this is the need, what we need dynamic models on extracorporeal therapies. But I had two questions. One is, apart from what sir has said, the important parameters, but where is kidneys here when we are doing CRRT and sodium and other parameters? How did you select which parameters? You didn't show us. First question. The second is the baseline parameters. Like if I could have assessed at baseline itself, these patients will die, irrespective of whether you do plasma exchange or not. That data was not there.
Yes, ma'am. I'll answer the second question first. The T0 data, that is before doing plasma exchange, can be predict, and that is always better than the post. So this pre plasma exchange prediction was very good. It was greater than 85%. There are other ways to predict, but we kept our focus on once we start plasma exchange, because our whole idea was once the plasma exchange plays havoc with our biochemical parameters, how do we decide after that? So yes, that point is valid, but that is for this study, we studied only removed this part of T0. We didn't show it here
That should
because
also come out from your study where we were able to change the cost with all these therapies.
Yes.
So baseline itself is very important, and that is also what is needed, because we do not have models in pediatric patients for predicting which patients would die and which would get better with extracorporeal therapies.
I have also skipped, for the need of time, the univariate analysis, which was done prior on the whole data, and where other parameters were excluded. See, this was the variables which were included after univariate.
Maybe you
analysis.
just note the point,
Yeah.
Vikrant.
Yes.
Isha.
Hello.
Yeah.
Yes, sir. Sir, excellent study and excellent presentation. I question, in the methodology, there was SMOT method used for sample size increase. So my question is whether in the web-based tool, is it the model with SMOT or without SMOT?
Yeah, so this much I am aware of, so I should be able to answer this. I have also written that augmentation, that SMOT augmentation was applied only to the training data and not to the validation data. And the final data which was presented, the 3 models which are presented in the final web deployed model, are the without SMOT ones.
Okay, so we do training with SMOT and
Yes.
always we do validation without SMOT.
So that is what we have done.
So,
And
yes.
even I have shown that SMOT actually doesn't add too much. You can see that the AUROC improved by around 0.02, 0.3, 3% improvement in the results
Yes.
with SMOT. So we decided to keep the data without SMOT, which is actually
Yes.
more reliable and less
Yes,
risk of
yes.
overfitting. And
With SMOT, it is always like that. It will boost the result accuracy, but always there is bias. So generally we use without SMOT model, and when we do multicentric external validation, we have to see whether the without SMOT and with SMOT, how the both model is performing, so to identify the amount of bias. So
Yes.
that was one comment, and with this, I would like to welcome all department faculties to have this type of study, and I'm here for that. I want to utilize my skill, and already I have done this type of things, and you can come to me.
So
So,
when
I welcome.
there is a Saturday class which Isha takes, very few residents and faculty go, we can restart it. And thank you, Vikrant. It's very nice. A big round of applause. Very, very good. Okay. Isha runs these classes on Saturday, I think 3 to 5 on AI and machine learning. Okay. 4 to 5, sorry.
So thank you, Vikrant. And moving ahead to a different topic altogether. So I have given a topic of steatotic liver diseases, histopathological aspects. So only disclosure I have here, I am not a histopathologist. So what I'll do from a clinical point of view, what does the histopathology of steatotic liver diseases or MASLD or whatever you want to call it, I'll give an overview on that only. So let me start with the thing that all fat in liver is not MASLD. This is especially true for pediatricians because we know we want to exclude the genetic liver disorder. So every ultrasound which carries a fatty liver report does not mean that it is MASLD. Especially for us, you can have genetic metabolic liver disorders, medications, dietary factors, infections. And this is the important group which I would say adult hepatologists usually miss. And this has been proven in studies that if you look at larger pediatric hepatology units, only about 50% fit into your classical MASLD. Almost 40% are not MASLD. They are MLDs. These are ultrasound showing fatty liver with or without biopsy being proven. So I'll go through some cases. These are real life cases, published cases. First two cases are from our department. Rest of the two cases I highlighted because these are adult patients. So if you see younger patients coming with upper abdominal distension, hepatomegaly ultrasound showing fatty liver. But if you look at these two cases, adolescent girl and a 28-year-old female, they have been carrying a diagnosis of lean MASLD and NASH for 2 years and 10 years. Before somebody decided to take a detailed history in which she had a history of neurological involvement 2 years back, and she had a history of recurrent episodes of low energy, lethargy, decreased appetite intermittently. When somebody started to investigate, they could find a mitochondrial hepatopathy or a FAOD related gene defects into these two cases. So they were labeled as lean MASLD or MASH, but subsequently we could diagnose them as mitochondrial hepatopathy and FAOD after so many years of lean diagnosis. If you look at their biopsies, they all look the same, don't they? All look steatotic, and you cannot differentiate between these two. I'll give you another case, adolescent case, which adult hepatologists would also see. A 14-year-old guy who is coming with recurrent episodes of pancreatitis, is lean MASLD, has acanthosis, insulin resistance, and grade 3 fatty liver. Was subsequently diagnosed to have familial lipodystrophy. But look at the biopsy. He had 11 episodes of pancreatitis second to this genetic disorder. So the message here is that first message is that if you see a biopsy or ultrasound showing fatty liver, it does not always mean MASLD. There are always pitfalls and fallacies. If you start evaluating without a clinical concept, irrespective of the age, whether it is a child or an adult, you can have a misleading interpretation, and it is applicable to both of these, especially if you label a patient as lean MASLD or MASH. So I cannot go much into the detail of pathophysiology of MASLD, but only a couple of slides. So once you start ingesting your lipids, it gets packed into chylomicrons, goes into the capillaries. This lipoprotein lipase acts on these chylomicrons. The fat which is released goes inside through apolipoprotein E, and this cholesterol and free fatty acid either undergo de novo lipogenesis because liver wants to utilize this fat, or it will try to excrete and remove the fat from the liver through VLDL, which subsequently converts from VLDL to intermittent density or low density lipoprotein, which can either go back into the liver through these LDL receptors, or it can subsequently get metabolized in adipose tissue and bones. So there are only two ways you can have fatty liver. And this has to be a balance between the lipid acquisition and the lipid disposal. So if you take a very high carb diet, through these carbohydrate responsive element binding protein or sterol responsive element binding protein, which are master transcription factors, it can lead to increased de novo lipogenesis. That means the liver is trying to convert this carbohydrate back into the fat. Or if you have insulin resistance or increased lipolysis in the adipose tissue, which increases the free fatty acid efflux into the liver, this causes your free fatty acid accumulation. And you should understand that free fatty acid are toxic, but liver wants to convert them into an inert substance, which is a triglyceride. So what happens to this triglyceride? Either it can get oxidized to fatty acid oxidation, which usually happens in mitochondria.
But when you have lipotoxicity because of excessive triglyceride, it can convert this oxidation to gamma or omega oxidation, which happens in peroxisomes and lysosomes. But if you have a defect here, that these are not getting oxidized or these are not getting excreted through this VLDL due to impaired efflux or utilization, this causes hepatic steatosis. So I'll go brief into the histopathology. That is my main topic. And if you look at the MAFLD or MAFLD, whatever you want to call it, there are only three categories. One is steatosis, one is activity in the form of ballooning degeneration, and fibrosis. I'll focus most on steatosis and predominantly of ballooning degeneration because that is the most important prognostic factor. I'll not go into the detail of fibrosis because it is very well known. So these are all the beautiful diagrams which have been provided by Department of Pathology. You have pan-acinous steatosis, you have zone 1 predominant steatosis, you have lobular inflammation, significant portal inflammation, ballooning, and predominantly type 2 or zone 1 predominant NASH. So previous terms that were used to define steatosis were macrovascular and microvascular steatosis. We have moved slightly away from these definitions. What we currently use are a large droplet type macrovascular steatosis. That means you have a large steatotic vacuole inside the liver, which is larger than the surrounding non-steatotic hepatocyte. And previous terms, they used to use more than 200 micrometer per square. And the second term, they have differentiated macrovascular into a small droplet type. So there is a large droplet and there are smaller droplets. Or you have a microvascular steatosis in which you cannot see the droplets per se, but there is a foamy cytoplasm and the size is roughly less than 2 micron per meter square. The second important component is hepatocellular ballooning. So what is ballooning per se? Ballooning means the hepatocyte gets enlarged. There is a rarefied cytoplasm with a larger hyperchromatic nuclei and a larger nucleolus, which is secondary to keratin degradation. So if you see the HE, there is a large hepatocyte, rarified cytoplasm, and you should see that this bluish one is the cytokeratin. This is the cytoskeletal component of your hepatocyte. Usually it should be a uniform appearance. Everything should be brown, compared entire cell. But what you see here is that the cytokeratin is getting accumulated or aggregated to smaller size. And secondarily, if you use the ubiquitin, which is a ER stress marker, you will see these. These are what are typically, these are the Mallory-Denk bodies, which secondary to keratin degradation, this happens. And the second important component is Sonic Hedgehog, which is named by the video game character. What this tells you is that normally the hepatocyte should not show any Sonic Hedgehog. Hedgehog is nothing but a marker of ER stress, which subsequently happens when the hepatocyte gets ballooned and it causes a diffuse hepatocellular staining. So this is pathological. So why is it important? Because studies have been done. They have shown that if you give a marker like tunicamycin, which is a ER stress inducer, it will cause your cytoskeletal. This is K1819. This is normal. If you give it, the cytoskeletal will break down. K18 and 8/18 will go down. Ubiquitin, which is a stress marker, will start increasing. Your Sonic Hedgehog and Indian Hedgehog both will start increasing. So what it does is, Sonic Hedgehog acts in a paracrine manner. ER stress is induced, cytoskeletal gets broken down, starts aggregating in the form of ubiquitin, gets aggregated by P62, and then causes a release of Sonic Hedgehog, which acts in a paracrine manner around the hepatocyte, not in the hepatocyte per se, and subsequently causes alpha SMA or activates the myofibroblast, which is surrounding the hepatocyte, and subsequently causes fibrosis. So therefore, ballooning has been correlated with fibrosis per se, and you can see as the number of Sonic Hedgehog positive hepatocyte go up, the ballooning and the fibrosis starts progressing. And this has been shown. This is the study from the Pivens trial, if you remember, from NEJM in 2010. And they have shown that the Sonic Hedgehog pre-treatment and post-treatment with vitamin E only. They have shown that these are 59 cases they could evaluate, 30 and 29 on both sides. And they have shown that if you give treatment, the Sonic Hedgehog levels or the staining goes down, and K18 and the cytokeratin markers, which were aggregated, now start becoming diffuse or becoming normalized over the time. and the GLI2, the progenitor marker like SOX9 or alpha SMA, their levels go down once you start treating them. And also HSP27, the heat shock protein 27, it is a antioxidant marker. Body feels stress, it produces HSP27 and helps prevent the cytoskeletal, prevent the oxidant stress. But if you see the patients who have a significant ballooning, what they show you that the HSP27 immunostaining goes down. So these cells have been called as something like undead cells. So what happens is, if you have a lipotoxic insult, if it is lethal, which is usually not there in mast cell, you causes apoptosis. But if it's sublethal, that means the cells are not being died, they become ballooned with mammary bodies, and they may, or subsequently, they may release these extracellular vesicles. Maybe Dr. Sukriti would be able to explain it well. So these extracellular vesicles may act as dams, may cause macrophage activation and infiltration, may cause endothelial migration, and may even cause, depending on the specific type of extracellular vesicles, can cause the myofibroblast or HSC proliferation, leading to fibrosis. So before we go ahead, before I explain the ILBS experience, I'll just briefly go to the scoring systems, these are important for use in mast cell. Starting from 1999, when Dr. Lisa M. Brent presented these data from University St. Louis, the second scoring system that came up was the NASH CRN, or Clinical Research Network. They use steatosis, lobular inflammation, and balloon degeneration. The entire term, they call it as NAFLD activity score or NASH score, and more than 5 was labeled as NASH. But these had issues because they were never designated to diagnose NASH. So predominantly we use it not to diagnose NASH per se, but to track the severity and assess treatment response. And this is the most common scoring system that they use. The second came by Professor Bedossa from France. This was a single center study to begin with. Then they validated using this fatty liver inhibition progression by 8 European centers, using 12 hepatologists. So the terminologies remain the same, the steatosis, but they differed that activity would include only lobular inflammation and balloon degeneration. They are almost the same, some bearing variations that the number of how would they score balloon degeneration or lobular inflammation, but the parameters remain the same. And what the best thing about this FLIP algorithm or SAF algorithm is that it does not categorize borderline NASH or NASH. It gives you either it is NASH or not NASH. They are absolutely clear. So, and the third parameter, which is used in pediatric populations, but not very well validated. This came from 2 centers, one from, I think, Hopkins and one from in France. And what they gave is that they included portal inflammation, because they say that children have less classical ballooning and more portal inflammation. And they came up with this mathematical score. But what we use here, we give you both. At ILBS, we give you a NASH score and we give you SAF score. So you can use both of them for your practice. So I'll briefly go to the ILBS experience. Thanks to the Department of Pathology. What we did, we wanted to categorize, because there is limited data on overall the pediatric aspect of histopathology of mast cell. So give you a classical histopathological spectrum and also evaluate the role of non-invasive modalities with histology. So over the years, we had 136 biopsy proven mast cell. After excluding those we could not reevaluate on pathology. We looked at all these parameters, looked at the inter-observer agreement, and also tried to predict the fibrosis predictors. So let me start. We used 2 pathologists, 2 independent pathologists. They evaluate these slides separately, and both of them came with a very good agreement, inter-observer agreement. The steatosis grade, predominantly 2/3 had higher grade of steatosis, and predominantly it was a zone 3 central. That is not unlike the previous data that we had seen, that pediatric population is zone 1 or portal predominant. But the surprising thing was that almost 10% had advanced fibrosis and almost 4% had cirrhosis in pediatric population. If you compare it with the previous literature, this proportion of cirrhosis varies from 2 to 4%, and the advanced fibrosis, which we call it as F3, F4, varies from almost 1/5 of your overall patients. So these are sicker patients. We cannot neglect, but there is always a referral bias because we are seeing the more sicker or MASLD patients. There was significant ballooning, portal inflammation and lobular inflammation was also seen in a significant proportion of subjects. And Mallory-Denk bodies were only seen in 17%. So if you look at all these three parameters, the best modality to diagnose MASH was the SAF score, because only 50, if you use the NASH CRN and give a cutoff of more than equal to 5, only 50.7% could qualify as MASH. So SAF score still gave us the best term. And there is a controversy which I was alluding to earlier. Previous literature, starting from Professor Jeffrey Schimmer in 2005, they had tried to differentiate pediatric, that is the type 2 NASH versus the adult type, which is type 1. But what we found is that predominantly it was a mix of overlap. We had almost type 2 was only 1.5%. We predominantly had a type 1 or an adult type of this. So what is an adult type? What they say, it is a zone 3 predominant changes. Steatosis would be there would be a perisinusoidal fibrosis or the chicken wire fibrosis, they say, and the ballooning degeneration is higher. But in children, what the Jeffrey Schimmer had shown that almost 60% had a predominant. But this literature did not go beyond early 2010. Some studies tried to overlap it, but now the latest studies have not tried to differentiate type 1 and type 2. They only tell you what is the exact finding. And this is important because we try to evaluate whether the cap that you see on FibroScan or the LSM that you see on your FibroScan, does it correlate with steatosis on biopsy and fibrosis on biopsy? So there was poor correlation between cap and steatosis, but a good correlation with LSM and fibrosis. What does it mean? On ordinary logistic regression, though there is a poor correlation, but there is a trend that as the cap goes high, your steatosis grade on biopsy will also go higher. Also, as your LSM goes higher, there is a 29 increasing odds of higher histological fibrosis grade. I'll show it in the form of a diagram. There is no good correlation between cap and steatosis on biopsy. You see the biopsy, even in stage grade 1 steatosis on biopsy, your cap values 1, 2, 3 remain almost the same. There is an increasing correlation between LSM, but this is okay. And this is not our only finding. And almost I'll show you that not even your area underscore, we could try and come up with the cutoffs, but the area underscores were not very good. There should be at least more than 0.8, something like that. And this is not our only finding. If you see the largest study from NASH CRN group in pediatric age group, they could also find that there is no correlation between your cap and your LSM that you find on fibrosis versus your biopsy. Look at there. There also they all could find even with the stage 1 steatosis, your cap in stage 1, stage 2, stage 3 looks almost the same. So you cannot differentiate. People have tried to give a cutoff. I'll show the cutoffs also, but not very helpful. And even their fibrosis grading on FibroScan versus your steatosis, not very good area under curves. And previous cutoffs, people had tried to in pediatric age groups, have given a cutoff for diagnosing steatosis roughly varying from 225 to 260. But as you can see here, it is not very helpful. And just as a predictor, fibrosis, higher AST levels, and portal inflammation were the two only independent factors. So last concluding slides, the way forward is always AI, machine learning, digital pathology. So what is digital pathology per se? What you do is you take try and convert the pathological slides that you have into whole slide images. You take so that your resolution becomes higher. You digitize them. It is like looking at a Google map on a biopsy. You know where is the hepatocyte, where is the fibrosis, where is everything. And what it tells you, this is the classical picture that you see. But if you try and do it using machine learning and AI, it will give you something like this. Green one is the fibrosis, blue is the ballooning, and purple is the inflammation. It gives you a more, I'll say, a more representative picture, more easier to see. Also, it can tell you that if you look at the mesentericum, this is how it will give you this. So I'll give you an example. It will say, if pathologists would say that the fibrosis is stage 1, say 0 to 5 to 33%, but this would quantify it as, it would say 22.5%. If you see fibrosis, we would say stage 1 or stage 2, it would say stage 1.7 using the collagen proportionate area. So it can tell you that if you see this study, they have shown that for a one-stage improvement that we classically use in all the clinical trials, the numbers are lesser. But if you try and use the delta fibrosis scale, which is one of the scores that you use, you can see a very significant improvement, though it is very, very sensitive to change. It does not has to categorize into stage 1, stage 2, stage 3. It can go in between those stages. It can have very significant or better intra-observer or inter-observer agreement. It is not subjective. And the second important is second generation microscopy. Harmonic biopsies or two photon excitation fluorescence microscopy. These are just second and third generation microscopies. You look at these pictures, they will show you pictures like this on harmonic biopsies from HE, Mason's trichome. This is how they tell you. And what they can quantify here is that if you look at the biopsies, these are your run-of-the-mill biopsies. But if you use these harmonic or second or third generation biopsies, it can quantify. These are Q fibrosis, Q fibs machine learning scores, which can quantify that your levels have gone down from 4.5 to 3.2, much more sensitive and less subjective. So my take-home messages is clinical context and pathology are key to your interpretation, and the future lies with the digital pathology, machine learning, and second generation microscopy, as is in any other field. And to acknowledge Professor Archana ma'am and Department of Hepatology, before I end, I would highlight that this work would not have been able to be finished barring the help of Dr. Ashray Patel and Dr. Megha Bansal. So thank you again, and to all the faculty of the departments. Thank you.
Very nice, Vikrant. Any comments from Archana or anyone in pathology? While you're waiting, the three types of fibrosis: pericellular, perisinusoidal, and periportal. And I thought we were missing on pericellular.
So I deliberately didn't pick up fibrosis because I did not go into detail of fibrosis per se.
And in the peds, probably pericellular might have a different connotation. I do not know. Secondly, zonation. And thirdly is the CPA, collagen proportionate area.
Yes, sir.
So I would like first Archana to comment and see whether this is relevant.
Yeah, we had detailed discussion before his presentation because this was pathology. So how it would be. So he has covered that. Main point was, as he mentioned, type 1, type 2. Cases don't fit. There are a group of cases which don't fit into one of those categories. So we have to look or follow up those cases and collect those cases. That's an important category. And related to AI modeling, Dr. Isha can help with your cases. We can redo these cases in a different way in these three categories, and you can prepare AI model on stained slides, MT, Picroseries. So that we can do on these slides.
Very beautiful pictures you picked up, Grant, those keratins, cytokeratins and all that. And the Pevens trial data, I remember the paper so well, how vitamin E came in.
Vikrant, very nice presentation. So just few queries and discussion point. I'm just surprised why biopsy and fibroscan don't correlate. Do you have any reason for that? Second, my query was 136 patients you evaluated with NASH, right?
Yes.
And then all of them had biopsies done, right?
Yes, sir.
All of them.
Yes.
So were there any ones where there was a clinical suspicion for NASH, but biopsy didn't show NASH? How good was clinical context in terms of diagnosing NASH in children? That is first point.
Yes.
Then was there a correlation between biopsy and clinical suspicion? And obviously you already shown fibroscan doesn't correlate with biopsy. So there are lots of big question here that because normally it is fibroscan which is being used for screening modality. So how effective it can be because it is being now sold like anything. Fibroscan has become like an OPD, it's stethoscope for liver, right? So we really have a big question how to put that in context.
Sir, I'll show here that
we did find a correlation between LSM and fibrosis. So as the grade of fibrosis was going up on biopsy, LSM also was increasing. But this has not been found in the study that was, in the study that did that in states. They had almost more than 100 children, and in which you will see that you cannot differentiate stage 1, stage 2, but stage 3 and 4 you could differentiate from stage 0, but still they did not find a good correlation. But we did find, not in CAP, but LSM we did find. So we have seen, my personal experience is that LSM is always falsely elevated, not at the right level. I have seen a fibroscan of 15 to 20, but the biopsy only showing significant inflammation and only stage 1 or stage 2 fibrosis. So it is sometimes falsely elevated also. So, but as their inflammation and ballooning goes down, their fibrosis also goes down. And I would say in MASLD, the cirrhosis is always an incidental diagnosis. We never had a clinically symptomatic MASLD child who had overt features of cirrhosis on examination. These are only biopsy findings.
So is there a difference in fibroscan reading between children and adults?
No.
Because normally, we do like lots of donors. When you have a younger donor, the liver is a bit different. It's not as, the softness comes with the age as well. And then when it gets then it will become firm. But younger donors, they have sort of firm consistency. So I presume I don't know whether there is a data out there or not, that children's fibroscan reading will be very different from
They
adults.
have a different probe, pediatric probe, which they use, which has a lower megahertz. But the point is valid. There are very few studies on correlation of, the fibroscan using pediatric and the fibrosis. It itself can be a separate paper of correlation or false positive. Generally, it's not overestimates, it's underestimates in the clinical scenarios. But anyway, we need much more to learn. Thank you for this very interesting paper.
Thank you.